Welcome to Chapter 15. Here we will discuss oncology, nursing management, and cancer care. Please be aware that during this basic adult health course, you will only cover half of this chapter. The other half of the chapter will be covered in advanced adult health. When we look at cancer, it is not a single disease with a single cause. Rather, it is a group of distinct diseases with different causes, manifestations, treatments, and prognoses. Because cancer can involve any organ system and treatment approaches have been or have the potential for multi-system effects, cancer nursing practice overlaps numerous nursing specialties. Cancer nursing practice covers all age groups and is carried out in various settings, including those of acute care, outpatient, rehabilitation, home health care, and long-term care facilities. Cancer nursing practice addresses the care of patients throughout the cancer trajectory from prevention through end-of-life care. Despite significant advance in understanding cancer, including causes, prevention, early detection, diagnostic tools, prognostic indicators, treatment, and symptom management, many people still associate cancer with pain and death. As nurses, you need to identify your own perception of cancer and set realistic goals to meet the challenges inherent in caring for patients with cancer. In addition, nurses for patients with cancer must be prepared to support both the patient and their families through a wide range of physical, emotional, social, and cultural, financial, and spiritual challenges. When looking at the malignant process, one must understand that cancer is a disease process that begins when a cell is transformed by genetic mutations of the cell DNA. Genetic mutations may result from inherited and/or acquired mutations that lead to abnormal cell behavior. The initial genetically altered cell forms a clone and begins to proliferate abnormally, evading normal intracellular and extracellular growth regulating processes or signals, as well as other defense mechanisms of the body. During the lifespan, various body tissues normally undergo periods of rapid or proliferative growth that must be distinguished from malignant growth activity. Several patterns of growth exist, including hyperplasia, metaplasia, dysplasia, anaplasia, and neoplasia. In order to review those terms, please see Chapter 6. Cancerous cells, described as malignant neoplasms, demonstrate uncontrolled cell growth that follows no physiologic demand, that being neoplasia. Although they're both benign, meaning non-cancerous, and malignant growths are classified and named by tissue of origin. Benign and malignant cells differ in many cellular growth characteristics, including the method and rate of growth, ability to metastasize or spread, general effects, destruction of tissue, and the ability to cause death. The degree of anaplasia, which is the pattern of growth in which the cells lack normal characteristics and differ in shape and organization with respect to their cells of origin, is also associated with increased malignant potential. Despite individual differences, cancer cells share common behavioral capabilities that foster uncontrolled growth, survival, and the ability to invade adjacent tissues and/or spread to other body sites. These capabilities include uncontrolled proliferation, evasion of growth suppression signals, replicative immortality, invasion and metastasis, resistance to cell death, uncontrolled angiogenesis, which is the growth of new blood vessels that allows cancer cells to grow, reprogrammed cell metabolism, and evasion of the immune system. Malignant cell membranes have been found to contain proteins called tumor-specific antigens, also known as TSA. These proteins distinguish malignant cells from benign cells of the same tissue type. Many of the TSAs that have been identified have aided in assessing the extent of the disease in a person and in tracking the course of illness during treatment or relapse. Malignant cellular membranes also contain less fibronectin, which is a cellular cement, making them less cohesive and less likely to adhere to adjacent cells readily. Typically, nuclei and cancer cells are large and irregularly shaped. Mitosis, which is your cell division, occurs more rapidly in malignant cells than in normal cells. As the cells grow and divide, more glucose and oxygen are needed. If glucose and oxygen are unavailable, malignant cells use anaerobic metabolic channels for cell proliferation. Cancer cells utilize an increased amount of glucose even in the presence of oxygen. This is known as the Warburg effect. This increase in uptake of glucose is the basis for the positron emission tomography, also known as the PET scan. Malignant diseases have the ability to spread or transfer cancer cells from one organ or body part to another by invasion and metastasis. Invasion, which refers to the growth of the primary tumor into the surrounding host tissues, occurs in several ways. Malignant cells are thought to possess or produce specific destructive enzymes and such as collagenases, plasminogen activators, and lysosomal hydrolysis. These enzymes are thought to destroy surrounding tissue, including the structural tissues of the vascular basement membrane. This facilitates invasion of malignant cells into the blood and lymphatic vessels. The mechanical pressure of a rapidly growing tumor may also enhance this process. I do want you guys to also look at chart or table 15-2 in text on page 313, which goes over the characteristics of benign and malignant tumors. Looking at metastasis, this is the dissemination or spread of malignant cells from the primary tumor to distant sites by direct spread of tumor cells to the body cavities or through lymphatic and blood circulation. Note that lymph and blood are key mechanisms by which cancer cells also spread. Lymphatic spread, which is the transport of tumor cells through the lymphatic circulation, is the most common mechanism of metastasis. Malignant cells also may penetrate lymphatic vessels by invasion. Tumors, such as breast tumors, frequently metastasize in this manner through the axillary, clavicular, and thoracic channels. Hematogenesis spread, which is the dissemination of malignant cells by the bloodstream, is directly related to the vascularity of the tumor. When we look at angiogenesis, this is the growth of new blood vessels from the host tissue stimulated by the release of growth factors such as vascular endothelial growth factor. Here in this slide, you will refer back to table 15-2 in your text on page 313 that goes over the characteristics of a benign and malignant tumor. Here is a true or false statement in regard to malignant tumors and the way they spread. The answer is true, and the rationale is provided here for you. When When we look at carcinogenesis, or the carcinogenic agents and factors, note that malignant transformation or carcinogenesis is thought to be at least a three-step cellular process involving initiation, promotion, and progression. Agents that initiate or promote cellular transformation are referred to as carcinogens. During the initiation, carcinogens, which are those substances that cause cancer, such as chemicals, physical factors, and biologic agents, cause mutations in the DNA. Normally, these alterations are reversed by DNA repair mechanisms, or the changes initiate programmed cellular death, which is your apoptosis or cell sequence. These mutations usually are not significant to cells until the second step of carcinogenesis. During promotion, repeated exposure to promoting agents, which are those co-carcinogens, causes proliferation and expansion of initiated cells with increased expression or manifestations of abnormal genetic information even after long latency periods. The promotion phase generally leads to the formation of the preoplastic or benign lesion. During progression, the altered cells exhibit increasingly malignant behavior. These cells acquire the ability to stimulate angiogenesis, to invade adjacent tissues, and to metastasize. Factors implicated or known to induce carcinogenesis include viruses and bacteria, physical agents, chemicals, genetic or familiar factors, diet, and hormones. Looking at viruses and bacteria, it is estimated that about 20% of all cancers worldwide are linked to viral and bacterial infections. Examples of these viruses are known to cause cancer include the human papillomavirus, also known as your HPV, cervical and neck and head cancers, hepatitis B, which is your liver, hepatitis B, which can be your liver cancer, or your Epstein-Barr virus, usually found in your Burkitt lymphoma, nasal and nasopharyngeal cancers. There is little evidence to support the link of most bacteria to cancer, although chronic inflammatory reactions to bacteria and the production of carcinogenic metabolites are possible mechanisms that continue to be investigated. As for physical factors, these are associated with carcinogens, including exposure to sunlight or radiation, chronic irritation or inflammation, and tobacco use. Excessive exposure to ultraviolet rays of the sun, especially in fair-skinned people, increases the risk for skin cancers. Exposure to ionizing radiation can occur with repeated diagnostic X-ray procedures or radiation therapy used to treat diseases. Background radiation from the natural decay processes that produce radon has also been identified with lung cancer. Ventilation is advised in homes with high levels of trapped radon to allow gas to disperse into the atmosphere. When we look at chemical agents, many cancers are thought to be related to environmental factors. Tobacco smoke, thought to be the single most lethal chemical carcinogen, accounts for at least 30% of cancer deaths in humans. Smoking is strongly associated with cancers of the lung, head and neck, esophagus, stomach, pancreas, cervix, kidney, and bladder, and with acute myeloblastic leukemia. Many chemical substances found in the workplace are also carcinogens or co-carcinogens. When we look at genetics and familial factors, almost every cancer type has been shown to run in families. This may be owing to genetics, shared environments, cultural or lifestyle factors, or chance alone. Genetic factors play a role in cancer cell development. Specific cancers with underlying genetic abnormalities include your Burkitt lymphoma, chronic myelogenous leukemia, acute leukemia, retinoblastomas, Will's tumor, and other skin cancers, including malignant melanomas. The hallmark of families with hereditary cancer syndromes include cancer in two or more first-degree or second-degree relatives, early onset of cancer in family members younger than 50 years of age, and the same type of cancer in several family members, individual family members with more than one type of cancer, and a rare cancer in one or more family members. Looking at those dietary factors, they are also linked to environmental cancers. Dietary substances can be proactive or protective, carcinogenic or co-carcinogenic. The risk of cancer increases with long-term ingestion of carcinogens or co-carcinogens or chronic absence of protected substances in the diet. Dietary substances that appear to increase the risk for cancer include fats, alcohol, salt-cured or smoked meats, nitrate and nitritic containing foods, and red and processed meats. Of course, alcohol increases the risk of cancers, especially in the mouth, pharynx, larynx, esophagus, liver, colon, rectum, and even the breast. Poor diet and obesity have been identified as contributing factors to the development of cancers of the breast in postmenopausal women, colon, endometrium, esophagus, and the kidney. Obesity is also associated with increased risk for cancers of the pancreas, gallbladder, thyroid, ovary, and cervix for multiple myeloma. As far as hormonal agents, tumor growth may be promoted by disturbances in hormonal balance, either by the body's own, which is endogenous hormone production, or by administration of exogenous hormones. Cancers of the breast, prostate, and uterus are thought to depend on endogenous hormonal levels for growth. Hormonal changes related to female reproductive cycles are also associated with cancer incidence. Early onset of menses before the age of 12 and delayed onset of menopause after the age of 55, meaning never having birth, and delayed childbirth after the age of 30 are all associated with an increased risk of breast cancer. And here is the answer with the rationale. And lastly, within this chapter, we will talk about primary and secondary prevention. The primary, secondary, and tertiary prevention of cancer has become increasingly important for addressing cancer. All individuals are encouraged to comply with detection efforts which are suggested in your chart or in Table 15-3 by the American Cancer Society in your text on page 319. And within that table, it goes over screening guidelines for early detection of cancer in the average risk asymptomatic patient. So, of course, this would not apply to those who are already symptomatic or already have the disease. When we look at primary prevention, it is concerned with reducing the risk of disease through health promotion and risk reduction strategies. By acquiring the knowledge and skills necessary to educate the community about cancer risk, nurses in all settings play a key role in cancer prevention. One way to reduce the risk of cancer is to help individuals avoid carcinogens, especially the ones that are known. Another strategy involves encouraging individuals to make dietary and lifestyle changes, which can include smoking cessation, decreased caloric and alcohol intake, and increased physical activity. Studies show influence the risk for cancer. Nurses use their education and counseling skills to provide patient education and support public education campaigns through organizations such as the American Cancer Society. And lastly, looking at secondary prevention, this involves screening and early detection activities that seek to identify early stage cancer in individuals who lack signs and symptoms suggestive of cancer. The goal is to decrease cancer morbidity and mortality associated with advanced stages of cancer and complex treatment approaches. Many screening and detection programs target people who do not regularly practice health-promoting behaviors or lack access to health care due to health insurance issues, financial or transportation limitations, competing priorities, or even lack of knowledge. Nurses continue to develop evidence-based approaches for community-based screening and detection programs that reflect the cultural beliefs of the target population. And with that said, that will complete the portion of Chapter 15, Oncology, Nursing Management, and Cancer Care for Basic Adult Health. Again, the remainder of slides, starting with the diagnosis of cancer, will be covered and reviewed in Advanced Adult Health